Hello, my name is Lexi Gann. I'm a senior athletic training student and I will be presenting this concussion case study. The athlete presented in this case study is a 19-year-old male NAIA football cornerback. He has no history of a previously diagnosed concussion, no medical history of head injury or hospitalization due to head injury, no previously diagnosed learning disabilities or psychiatric disorders. From the beginning, it seemed like a clear-cut case. On September 26th, the athlete fell to the ground and hit the front of his head on the ground at football practice. The certified athletic trainer approached the athlete and discovered that he had a headache and balance problems. The athlete self-reported the headache and the balance problems were detected by using the modified BEST test on the field. The athletic trainer decided to remove the athlete from practice for the day and allow the athlete to attend the rest of practice but not participate. And then he was instructed to go home that night and rest. He was also instructed to come into the training room, the athletic training room the next morning to be evaluated again. So the following morning, September 27th, the athlete shows up to the athletic training room and fills out a SCAT-5 symptom checklist and reports 0 symptoms. During this evaluation, the athletic trainer sensed that there was some dishonesty and that the athlete didn't understand the implications of a concussion. So they had the conversation, educating him on what concussion is, what the implications are of second impact syndrome. And then the athletic trainer took the athlete outside to do some exertional activities. Did balance testing, he did sprints, skips, he did a suicide run. None of these exertional exercises provoked any other symptoms. There was no cognitive issues, no memory issues, no balance problems, and the athlete reported 0 symptoms following the exertional activities. The next day, that same day, the athlete returned to practice, so he's cleared to participate. The next day, he's still participating. On September 29th, the team had traveled to an away game. So that Saturday morning before the game, the athlete reports that he has actually lied in his previous evaluations and he's had a headache since he fell and hit his head. The athlete now reports that he has a headache, sensitivity to light, trouble focusing, and increased symptoms during class and football practice. The athlete was then instructed not to play in that game that night. The athlete attended the game since he was already there with the team traveling, and then was instructed to go home and rest on Sunday, and come back to the training room on Monday for further evaluation. Several years ago, this case may have been treated much differently. The athlete may have been put in a dark room with no sounds or lights, not been allowed to participate in any school or physical activity, or told to just push through the pain if they had symptoms like a headache. Now, our research has come a long way. Even in our NATA position statement, there's a section on using correct terminology and not calling a concussion a bell ringer or saying a ding, for example. Concussions are treated with much more seriousness, and we have a much better idea of how to treat them. So now the goals are to maximize rest and use an individualized plan for each athlete, to minimize how much time they lose in their classes, and to make appropriate accommodations for each and every athlete with their return to play and return to learn strategies. Now it is understood that each and every concussion is different and should be treated differently. The clinical concussion trajectories have been researched over the years, and they include vestibular, ocular motor, cognitive, post-traumatic migraine, cervical, and anxiety and mood. Each of these concussion trajectories has different symptoms. For example, the vestibular trajectory is typically characterized by dizziness, fogginess, nausea, overstimulation with complex environments, etc., whereas the anxiety and mood trajectory is more characterized by feelings of anxiety, being overwhelmed, sadness, hopelessness, etc. These trajectories should all be treated differently, so there should be a targeted treatment and rehabilitation plan depending on how your athlete presents. The return to play and the return to learn protocol will be different depending on the trajectory. You should have an interdisciplinary team that helps focus on the athlete. For example, if your athlete presents with more of the vestibular trajectory, you may need to involve a vestibular therapist or a physical therapist. If they have more of the anxiety and mood trajectory, you may need to involve a psychologist or psychiatrist. The clinical concussion trajectories can be used to categorize different symptoms that may be seen in a concussion, but oftentimes an athlete will fall into more than one of these categories. In this case study, our athlete mostly fell into the vestibular and the ocular motor categories. The symptoms were self-reported, including dizziness, a headache in the front of the head. You could tell he had trouble focusing when we were asking questions. He reported sensitivity to light and sensitivity to noise. These are all symptoms that are seen with those two trajectories. The BEST test was also completed by the athletic trainer, and it was noted that the athlete experienced trouble balancing even with his eyes open. This test can be shown in the image on this slide. The VOMS test was also performed, and the athlete had an abnormal near-point convergence. So these symptoms will mostly fall in line with the two clinical trajectories of vestibular and ocular motor. According to research, the return to play and rehabilitation protocol should be different depending on the different trajectories. Since this athlete mostly fell into the vestibular and ocular motor trajectories, we followed the rehabilitation process like so. The comprehensive vestibular therapy is recommended as part of the vestibular trajectory. It is also recommended to reduce strain on the visual system for the ocular motor trajectory. These methods were put in place by using vestibular therapy throughout our return to play protocol, and the athlete was also instructed to wear sunglasses anytime that the light was irritating his eyes. So the athlete wore sunglasses throughout the day, even indoors and out at practice. The return to play protocol, according to our NATA position statement, cannot begin until the athlete is symptom-free. The athlete initially reported 0 symptoms on October 3rd. So his return to play protocol began on October 4th through our 5-step process. On October 4th, the athlete completed light aerobic exercise, which was a 15-minute jog. The next day, the athlete still did not have symptoms and was able to progress to the next step of sport-specific exercises. He completed laps and sprints. Then he had the weekend off, and the next Monday he returned to the next step, which was non-contact training drills. After that, still having no symptoms, he started contact training drills, and the next day, which was October 10th, the athlete was finally cleared to play by the physician. Just like with the return to play protocol, returning to learn should be progressive as well. The athlete shouldn't completely be locked out of the classroom and schoolwork or any educational involvement. The athlete should go to class as they can, or they should make up work as they can without increasing symptoms. This involves an inclusive team: the coaches, the athletic trainers, all sports medicine staff, the athlete, the parents, the professors. Everyone needs to be involved in this plan. In this actual case, we had an altercation between the student and the professor when they wouldn't let them make up a discussion board post. The professor claimed that the student never turns these in on time anyway, which didn't help their case. But as in any concussion rehabilitation, communication is key. If the athlete had communicated better with their professor, there would have never been a problem. So just like return to play, the athlete should not completely shut themselves out. They should progressively return back to class as tolerated. The athlete in this case began their return to learn on the same time as their return to play. Once they were symptom-free, they returned to class and began their makeup work that they had missed in the past couple days. The takeaway from this presentation is that every concussion is different. This case study just presents one athlete, one concussion, one sport. A cookie-cutter approach should never be taken to the treatment and rehabilitation when it comes to concussions. Thank you for your time.